Thank you very much for that warm introduction, and I'm very grateful to Cigna for this support of my visit here. As you heard, I'm a great fan of public hospitals. My career has been very much shaped by public hospitals, beginning with Boston City Hospital, but especially with R.E. Thomason Hospital on the border of Texas in El Paso. I spent 11 years there as the only infectious disease person when I arrived there, shortly to be joined by two others. And I felt that most of what I learned in medicine, I cut my teeth there. I was very proud to go on from there to San Antonio, and now to be at Stanford, where we have a very strong association with Santa Clara Valley Hospital. So I admire greatly what you do. I admire your mission, and I'm deeply honored that you would ask me to be here today. I wanted to talk to you a little bit about an aspect of medicine that I'm not sure comes up in your boardrooms and your dialogues, but which remains very important to many of us on the front line. And I want you for a moment, if you don't mind, I want you to suspend disbelief and imagine for me an alien arriving on this planet, an alien who happens to be very much like you, interested in healthcare delivery, an alien who happens to be an internist, and we all know that aliens look like this. The evidence based on this is quite clear. We don't want to debate that. And this alien makes his or her its way to a hospital, very much like yours or mine, and decides to observe things from an internal medicine service by standing on the corner of a ward and just watching the activities going on. And you might ask, how could an alien get away with standing there and making these observations without anyone calling security or having them evicted? Well, it turns out the alien discovers that everyone is so preoccupied with the digital machines in front of them that no one really notices the alien being there. And so this alien is able to do some very sophisticated ethnographic studies of the nature of internal medicine care in public and other hospitals, and comes up with the following conclusions: that rounds, which the alien had read so much about, are actually removed from the living patient. That rounds are actually centered around an entity that I call the eye patient. I became very unpopular in Silicon Valley for coining this term, the eye patient, in an article in the New England Journal of Medicine, where I said that the patient in the bed has become a mere icon for the real patient who exists in the computer. And I coined the term the eye patient, like your iPad, your iPhone. And the eye patient is getting wonderful care all across America. The real patient often wonders, where the hell is everyone? Who's going to explain things to me? What's going on? The alien also observes that the bedside is somehow toxic, but some older doctors seem unaware of the hazards of the bedside, but everyone else, for the most part, seems to avoid it. And finally, the alien concludes that the purpose of admission is to take a live, three-dimensional human being and render them into a two-dimensional image that can be manipulated. That is the purpose and goal of admission. Now, obviously, I'm being very facetious. This is meant to grab your attention, but you might well ask, how did we get to a point where even this parody isn't that far-fetched? And it might surprise you to learn that our ability to examine patients is actually quite recent. Our diagnostic skills in actually reading the body as a text is a fairly recent phenomenon. When I talk to my medical students, they assume that we have known how to make diagnoses from the time of Hippocrates, but actually that's not true. It's fairly recently, and we can actually point to this gentleman, Joseph Leopold Hornberger, as being the first person to bring about modern clinical diagnosis. And the story about Hornberger is he was a physician in Vienna, and his father was an innkeeper. And one of Hornberger's powerful memories was his father going down to the basement of the inn and tapping on the sides of casks of wine to establish how much wine was left, where the meniscus was, and then reorder based on that. And so when Hornberger became a physician, he began to tap on patients' chests and bellies, and he began the practice of what we call percussion. And he wrote this wonderful book called Inventum Novum, New Invention. And ladies and gentlemen, everything we know about percussion, which physicians still do today, Hornberger described. There's been very little new added to that body of knowledge. What do you think happened to Hornberger for this wonderful new invention, the first time people were able to look into the body? forgive me, this is the pedagogue in me. I have to make sure that the back rows are alive and well and attentive. So what do you think happened to Hornberger for discovering this invention? Don't all speak at once. So actually it was roundly ignored, as you say. I mean, no one picked up on it. It was completely ignored. And he would have died with this wonderful technique never being recognized, but for the fact that this physician, who happened to be the most famous physician in Europe at the time, only because he happened to be physician to this gentleman. So Corvis Art picked up on Hornberger's work, and Corvis Art studied it, translated it into French, wrote a long introduction, and all of a sudden, percussion had arrived. You might be interested to know, the clinicians in this room especially, that when percussion was first described by Hornberger, they actually used a little hammer like that. They would not percuss the way we do now with our fingers, just with our fingers. They used an instrument called a pleximeter, that little band-like thing, put that on the chest or wherever, and then use the hammer to tap. And that hammer fell into disuse because people realized that you could actually tell a lot more by using your fingers, that you percussed to feel and not just to hear, that the vibration coming back to your finger was as important. So the hammer was abandoned, but became useful as the reflex hammer. So the modern reflex hammer has its origins in this entity. And very shortly after Corvis Art popularized percussion, his student Lenneck discovered auscultation, or the stethoscope. The story is that Lenneck was walking in the streets of Paris, and he'd been wrestling with this problem of how do you listen to patients' chests and abdomens. And they'd been doing it by applying the ear directly to the patient's body part. And as you can imagine, from time to time, that presents great aesthetic challenges. And so Lenneck was walking in the streets, and he saw two children playing with a stick. And one child scratched at the end of the stick, and the other listened at the other end. And it struck him that this might be a great way to listen to body parts. And so he invented a solid stick, called it the stethoscope. Actually, he called it the cylinder to begin with, and then he changed the name. And it morphed, it changed its shape, and finally became the stethoscope we know today. And so basically, by 1819, all of a sudden, there had been a huge change in the nature of physicianhood, because we had transitioned from the barber surgeon who you went to if you were ill, and the barber surgeon made no attempt at diagnosis. The barber surgeon would cup you, bleed you, purge you, pull your teeth, cut your hair, whatever you needed, with no attempt at diagnosis. And my medical students are often surprised when I tell them that the barber pole that you know so well has its origins in the bloody bandages that the barber surgeon would use to wrap up your vein once he had cut it. And the brass receptacles represent where the blood was collected. And so all of a sudden, by the carrying of the stethoscope in the pocket, physicians were signaling their commitment to making an etiologic diagnosis as opposed to treating blindly without any rhyme or reason, cupping, bleeding, purging. I must say, I favor the carrying of the stethoscope in the pocket. I have great objections to my students draping the stethoscope over their neck. I always think it's much more of a, when you do that, it's not an indication you're a physician, it's more a signal in elevators that you have great marital prospects, you have cows and property. It doesn't tell me anything about your clinical skills, so I'm unimpressed. And so by the late 1800s, we had come to this point in time where clinicians had an extraordinary ability to make diagnoses at the bedside. The blood pressure cuff had arrived, the ophthalmoscope had arrived, reflex hammers had arrived. This was the height of clinical acumen at the bedside. And I wanted to tell you a story related to Sherlock Holmes. How many of you know who wrote the Sherlock Holmes series? You want to shout it out, or? Okay, Arthur Conan Doyle. How many of you know who was Arthur Conan Doyle's inspiration? What caused him to invent Sherlock Holmes? Who was his inspiration for that? Anyone know? Well, it turned out it was one of his teachers by the name of Sir Joseph Bell, or Joseph Bell. And Bell was an extraordinary clinician. He was extraordinary, but he probably was not that different from the kinds of extraordinary clinicians who existed on both sides of the Atlantic. And Conan Doyle, writing many years later in The Lancet, described an exchange with Bell when he was a student. And he describes Bell sitting in the infirmary, students all around him, and a woman comes in with her child. And Conan Doyle describes the following exchange, which I think will give you an indication of the kind of acumen of that era. The woman walks in and says, "Good morning." Dr. Bell says, "Good morning, and what kind of crossing did you have on the ferry from Burnt Island?" The woman is shocked. She says, "It was good." And he says, "And what did you do with the other child?" She says, "Well, I left the other child with my sister in Leith." And he says, "And did you take a shortcut down Inverleith Road to get here today?" She's stunned. She says, "Yes, I did." And he says, "And would you still be working at the linoleum factory?" And she says, "Yes, I am." All this before she's even undressed. And then he goes on to explain to the students, he says, "You see, when she said good morning, I picked up her Fife accent, and the nearest town in Fife is Burnt Island, and she probably took the ferry from there. You notice that the coat she's carrying is too large for the child who's with her, and therefore she started on this journey with 2 children and dropped one off along the way. You notice that the clay on the soles of her feet is red clay. It's a variety not found within 100 miles of Edinburgh, except in the botanical gardens, and Inverleith Row borders the botanical gardens, and so she took a shortcut through there. And by the way, I was in Edinburgh a few months ago, and I asked a taxi driver to take me to this spot, and I was trying to explain to him, and I only got 3 words out before he says, "Oh, I know exactly where you want to go," because apparently I wasn't the first person to come check this out. And then he says, finally, "Notice the dermatitis on the fingers of her right hand. Such a dermatitis is unique to the factory workers of Burnt Island." You know, when I tell the story to my students, they love it. They came to medicine hoping that some aspect of this, the ability to read the body, would be part of their training. And I think they're quite disappointed when they find how much medicine revolves around the computer and ordering tests and how far we've gotten away from this. I wanted to share this painting with you. This is this is the most famous painting in medicine. It's The Doctor by Luke Fielders. It hangs in the Tate Gallery, has been continuously there for many, many decades now. But it's the most famous and iconic medical painting because it has a very interesting history. It has been on postage stamps, it has been on covers of all kinds of medical journals. Luke Fields was commissioned by Tate when he was building the Tate Gallery to paint a painting of social importance. And Fields decided that he would depict the doctor in our time. That was his goal. And the reason Fields chose this topic is his son Philip, 9 years of age, had died on Christmas Eve of 1887, I believe. And he was so moved by the physician who had held vigil during Philip's illness, short illness, that he decided to portray that in this painting. And I want to just lead you through this painting, if I may. You can see how the central image, do I have a pointer on this, by the way? I don't want to risk it, so, well, maybe this is a pointer. Yeah, okay. The central image is the child. The child dominates the pictorial space, and you can see the child appears quite sick. Something about the posture of the hand, so the passivity of it suggests a very ill child. The child is sleeping on 2 dining room chairs that have been pulled together, so clearly this is a child who normally sleeps on a straw pallet in the back of this fisherman's cottage. On either side of the space are the parents and then the doctor. And the parents, as you can see, are distraught, looking on. The wife is praying. The husband is looking anxiously at the doctor's face to see what the doctor's next expression might be. The doctor here is depicted in a very interesting fashion. Even though this is the era of the stethoscope, the ophthalmoscope, the blood pressure cuff, none of those instruments are depicted. I think Fields did not want to distract from the image of the physician. And we are caught by the singular attentiveness of the physician. There have been volumes written about what this painting means. Volumes and volumes. Everybody has a commentary on it. And I actually think that everything that's been written has gotten it wrong. This painting, despite the title, is not about the doctor. This painting is about you and me projecting ourselves into this role of being the sick person. This painting is about you and me identifying with this person, and this is the kind of attentiveness from a physician that we want. So the physician is not the center of the painting, the patient is. And this is about the kind of care we would want. It reminds me of the line in Luke, I think, which says, I was sick and you cared for me. I was hungry and you fed me. I was naked and you clothed me. It reflects that kind of Samaritan instinct, which I think is so much a feature of public hospitals in America, and which we are in danger of getting far away from, especially in hospitals that are not public hospitals. I've often wondered, what would Fields have depicted had he been asked to paint the physician in our time in 2012? What might that have looked like? And my guess is it might have looked something like this. And I think in the process we've lost something very valuable. This is what rounds looked like at Boston City Hospital a couple of decades before I was there. This is Maxwell Finland. By the time I got there, Maxwell Finland was in his 80s, still living in the hospital. Maxwell Finland was a longtime bachelor, lived in the hospital, jogged in the corridors, had been mugged there many times, wrote many papers with his secretary Mildred Barnes, and was deeply hurt when 20 years into their long association, she married one of his fellows. But we all thought he had many years to propose and never did, so he shouldn't complain. Around the bed, there's a who's who of infectious disease. That's Morton Schwartz, who was head of ID at Mass General. I think Jack Remington is somewhere in that picture. So this is a tremendous historical portrait, but it also shows you the style of teaching and rounding in those days when things were much simpler. The data points were simpler, the hospital stays were much longer. Very often, this is what rounds look like today. And you might well ask, does it matter? Maybe this is just the way medicine has evolved. And I want to share with you two anecdotes which have influenced me to think that it does matter. And I'll describe the two anecdotes to you. First of all, I had a friend who had a breast cancer when I was in San Antonio. And she had her lumpectomy locally and then decided to go, because she had the resources, to the best cancer center in the world for subsequent care. And she did a lot of research, including with a spreadsheet, to try and establish which was the best cancer center in the world for her to get her subsequent care. Finally went there, and then to my surprise, a couple of months later, I found that she was actually back getting her care from her local private practice oncologist. And it surprised me because of the effort she'd put in to interview me and a few other people to find this best place. And when I pushed her as to why she had come back, she said, and she was reluctant to tell me, she said the cancer center was wonderful. It was just great, beautifully coordinated care, valet parking, 5-story atrium, piano that played itself, appointments back to back. But, she said, they did not examine my breasts very well. Now, you and I might argue, they did not need to examine her breast. They knew her breast at the molecular level. They had scanned her inside and out. The sensitivity of the human hand to find something in one of her breasts is kind of a joke compared to what they did to her. But the point is, to her it mattered. To her, it reflected an inattentiveness that she was not going to abide. And so she came back to see her local oncologist, who every single time she goes to see this person would examine both breasts, including the axillary tail, would have her shrug and dig into the supraclavicular notch looking for nodes. And there was something about that ritual and the attentiveness of it that made her decide to get her care there. And I was very impressed. It really affected me to think that that perception was enough to change the direction of care for someone who could afford the best. The other anecdote is when I was in Texas, in El Paso, I had a reputation, I don't quite know how this happened, of being interested in patients with chronic fatigue. This is not a reputation you would wish on your worst enemy. And I don't quite know how it happened. These are difficult patients. They are difficult because their families often don't believe them. They've been rejected by the medical establishment. You and I think of them as a bit of a joke, and that's why we laughed when I said that. And so they come to you fully prepared for you to be the next in the long line of physicians who's going to disappoint them and let them down. And I recognized this fairly early on. And so with my first or second patient, I hit on this method where I allowed the patient to take the entire first visit to tell me their story without interruption. Ladies and gentlemen, the average American physician, I'm told, interrupts their patient in 14 seconds. And I held my peace for 45 minutes. And if I ever get to heaven, it will be because of this one thing. Because with every new patient, I held my peace for 45 minutes and I let them tell me their story. And I scheduled the physical exam for another visit, 2 weeks hence. And when they came, I had the entire time to do the physical. And so I could do a very thorough physical. I like to think that I do a very good physical exam anyway, but given that we no longer had to do the history, I could do an extremely thorough physical. And I remember my first or second patient in the series, a very voluble patient, even though we had agreed history was before this and physical was to follow, this very voluble patient continued to give me more history during the physical. And I decided to just commence with the physical. And so I began my ritual. We all have a ritual of examining patients. I begin by feeling the pulse, and while I'm doing that, I take a look at the fingernails, and then I look at the palm, and then I slide my fingers up to the epitrochlear node, and I'm into my ritual. And an interesting thing happened while I was examining this patient. As I slipped into my ritual and got going, this very voluble patient began to quiet down. And I had the very eerie sense, which I've written about, that the patient and I had slipped back into a primitive ritual in which I had a role and in which the patient had a role. And I remember just being in awe of something that was happening in the room. I don't want to make too much of it. And when I was done, the patient said to me with some awe, "I have never been examined like this before." Which, if it were true, is a real condemnation of our healthcare system, given how many people had seen this patient. And all I did was a routine physical exam. And then when the patient came to my office and had dressed, I would tell the patient precisely what they had heard at Mayo or Scott and White or wherever they'd been, which is, this is real, this is not in your head. The good news, it's not cancer, it's not tuberculosis, it's not histocoxy. The bad news is we don't know exactly what's causing this, but here's what we should do. And I would trot out what we do, which is graded exercise, supportive psychotherapy. We have a few other tricks up our sleeve. And I always thought that if the patient gave up the quest for the magic doctor, the magic test, the magic bullet that was going to somehow make them well, and instead, if they began a partnership with me towards trying to make them well, I always thought that if they said yes to that, it was only because I'd earned the right to tell them these things by virtue of the exam that I had done. It was terribly important. And when I got to Stanford, the lovely thing about being at Stanford is the hospital and the university are on one campus. And I was able to walk across to my colleagues in anthropology and present the story to them. And they immediately pointed out to me, "Abraham, what you just described is you performed a ritual." And they started to teach me about rituals. Rituals, they taught me, are all about transformation. We engage in rituals to signal a change of some sort, a crossing of a threshold. We have baptismal ceremonies. We have marriage. I mean, take marriage, for example. We marry with great pomp and ceremony and expense to signal our departure from a life of loneliness, solitude, and misery to one of eternal bliss. I don't know why you're laughing. That was the intention, was it not? Well, I would submit to you that the ritual of one individual coming to another and telling them things they would not tell their rabbi or their spouse, and then incredibly disrobing and allowing touch, which in any other context would be assault, I would submit to you that that is a ritual of exceeding importance. It's a ritual at the heart of healthcare. And if we shortchange that ritual, we do so at great jeopardy to the patient-physician relationship, to the very nature of healthcare delivery. You can sort of look at the process of teaching physicians how to examine a patient, and it has all the trappings of other rituals. It has all the trappings of other crafts. This happens to be a picture of an Indonesian ceremonial sword craftsman. If this individual does not pass on the craft to his apprentice, this rarefied craft will die. And it's very true of our profession too. If we don't teach people how to examine, we will lose these skills. There's always an apprenticeship. There's always specialized terminology which is mysterious to outsiders. There's often a very sacred space with the one participant wearing a sacred outfit. The furniture in the space does not resemble any other furniture in any other kind of room. And finally, the end product of that ritual is that it preserves the personality, the embodied identity of the patient. It validates the patient's complaint by focusing on that patient, not on their image somewhere else. It's a symbolic centering of attention on the body as a locus of personhood and disease. Recently, there's some data that's come across that I've come across that's been very exciting on the placebo. We're learning that the placebo is not about conning patients with a sugar pill. It's much more intricate than that. You can take a Parkinson's disease patient, give them a placebo, and measure dopamine levels going up in their brain, and their movement improve. Not every patient, but about 30% of them. You can give a patient with pain, you can give them a placebo that you show them that you're injecting into their IV tubing, and their pain diminishes. There's change in the endorphins in their brain. You can then give them a morphine antagonist, and the pain comes roaring back. In other words, we're learning that placebo is not about tricking people. Real neurobiological changes are happening, not all the time, but 30 to 40% of the time. And we're learning that you can have a placebo without a placebo. In other words, ritual, context, tone of voice, all these things matter in bringing about significant positive changes. You can also have a nocebo. A nocebo is the opposite of the placebo. A great way to do a nocebo is don't look at the patient, look at the screen, and treat them as a sort of a vehicle that holds an image of which you're interested in, and you will have a nice nocebo effect. What can we do to preserve the ritual? A sad fact, ladies and gentlemen, is that most of the time this ritual is being shortchanged because of time pressures, because of the fact that there's a test that you can order that's less trouble. But we at Stanford believe that this is an important skill to preserve, and we try and give it more than lip service. We are trying to sort of make people very good at the bedside so that whether they're in Haiti doing relief efforts and have no technology, or they're in Stanford where they have the best technology in the world, they don't order a test to confirm something that is so obvious and should have been obvious and has been obvious since the 1800s when Hornberger discovered these things. Rather, they should order a test to confirm something that they already know and ask a better question, not what the hell's going on in the belly, but I can feel the spleen, I can feel a mass. Is that mass connected to the spleen? These are the kinds of questions we hope people will ask of technology and use it more judiciously. I want to leave you with two thoughts. One is I want to assure you that I'm not a Luddite. I love technology. I practice in a very sophisticated facility. I've almost abandoned the stethoscope and I carry a V-scan. I carry a pocket ultrasound. I'm very willing to use technology at the bedside. As long as it doesn't involve my sending the patient away, everything I can bring to bear at the bedside, I will. I want to leave you with this quote from Osler, who says, "Every patient upon whom you wait will examine you critically and form an estimate of you by the way in which you conduct yourself at the bedside. Skill and nicety in manipulation, whether in the simple act of feeling the pulse or a minor operation, will do more towards establishing confidence in you than a string of diplomas or the reputation of extensive hospital experience." I would say you could extend this metaphor to a public hospital. The public hospital that treats the patient as an individual with skill and nicety in every phase of the encounter, from receiving to transportation to the physician interaction, to the nurse's interaction, to the cleaner who comes into the room. That will be at the heart of how a patient judges that hospital. I'll stop here and I'll thank you for being so very attentive. I appreciate that. Thank you. Thank you very much.
take some questions?
Yeah. I think there are microphones around. I'll be very happy to take your questions and comments. Don't all speak at once. And I don't have a plane to catch. I just came
I'm in
from
politics. It's easy. Good morning.
Good morning. How are you?
I'm Liz Niss, and I'm part of the governing board of Santa Clara County. So we're familiar with you, and I know you are with us. So what I've realized lately, because I use a clinic in Palo Alto, is that there is a very certain length of time each physician is allowed, because I can now go online and make my appointments online, which say 8:10, 8:30, 8:40, and so forth. If that is what's driving medicine, and I think it is because we all are concerned about the bottom line, how do you get around that, or how would you suggest that we get around that so that you really do get the kind of time you need with the patient without the whole day going off in another direction?
That's a great question. I mean, I think that I like to point out to my students that so much of what we're doing in medicine isn't driven by medicine, but it's driven by reimbursement. You know, and the fact is that if you're in primary care, you have to see 24 to 26 patients a day or more just to pay the overhead. And this is what I think is driving many good primary care people into concierge practice, where they can take their time. And so time is a big issue. I like to point out to my students that we're not paid to do things for patients in medicine. We're paid to do things to patients. If you can stick a needle in, stick a probe in, stick an ultrasound in, stick something in, you make a lot more money than if you can sit there and listen to the patient. So this is the anomaly of our system. Having said that, so I don't have an easy solution for that. I do think that if we are going to put our money where our mouth is, we need to invest in primary care, and we need to support it so that it becomes something that physicians can make a livelihood on and give the time for the physician to do it. Without that, I think it's going to be very, very hard. Having said that, I will say this though. There's a conception that listening to the patient and examining the patient is somehow not time effective or cost effective. And I don't think that's the case at all. We're actually doing a big study at Stanford looking at physician errors on the bedside exam. And we've collected about 250 anecdotes of oversights that only other physicians will pick up on. And each one of those oversights led to some sort of misadventure. You know, radiation exposure, contrast exposure, unnecessary consults, which led to unnecessary, surgical misadventure. My point is that you save time and money by listening to the patient and examining them, at least in a brief, quick way. And I think we need to teach people the skill to be able to do that. So to do that doesn't take a lot of time. And I often think that, sometimes our house staff will be called to see a patient, and it's easier to order a CAT scan and leave that on the checklist for the next person on the shift to follow up on. Follow-up results of CAT scan. That's quicker than going to see the patient and realizing that, the belly pain is actually chest pain, or realizing that the belly pain is accompanied by a rash and they have shingles. These are things that are great wasters of time when people order tests. So I agree with you. I think that time is at a premium. And my time is at a premium when I'm seeing patients too. And if I recognize that I need to spend more time with the patient, I will either reschedule that patient for a longer visit, or there's often one patient in every clinic where I have to bump things because this is unanticipated and needs more time. But for the most part, I think you're quite right. We are not putting our money where our mouth is in terms of reimbursement and time, and that's a key issue. I like to point out to my students, you see freestanding birthing centers, freestanding surgical centers, freestanding cardiac centers, freestanding cancer centers. Anybody seen a freestanding geriatric center? With a 5-star lobby and a concierge service and valet parking? And yet, as a society, what is our greatest need? My parents are in their late 80s, and God knows they need a physician who can listen to them, and that takes a good half an hour. And then explain things to them after examining them, that takes another good half an hour. And if we don't value that, then they get the kind of care which they're getting now, which is frustration at the short visit, frustration that nothing's explained, and ultimately missing appointments because they just don't want to deal with the system. Sir.
So take that a little further in terms of how you get that space where that patient and the physician have that time, what is the role of public policy, of government, in payment systems and making that happen? You know, many of us in this room think that that's always the ultimate lever. We may be wrong. But that's how we think about it as an organization. And you know, what is the role there to allow that space to actually take place? Or is it, you know, perhaps more dangerous in some ways?
Well, I think, you know, all of you in this room, if you believe in this, you have to lobby for primary care. I mean, right now, I mean, look at how money comes to you. We are paid to do things in the emergency room. The more tests you order in the emergency room, the more money you make. Isn't that correct? I mean, am I getting that right? Whereas the same test, if you order it once the patient's admitted to the hospital, you lose money because of DRGs and so on. I mean, we're all trying to game the system to make money, and frankly, we've got to change reimbursement. So I think if we pay well for the primary care visit because we recognize that's the heart of our healthcare delivery, then I think we create more and more primary care specialists. There are no primary care specialists that we are training at Stanford that I can tell. We're training a bunch of specialists. Specialists order more tests. What we need is a very healthy way of attracting young graduates to primary care medicine. And you can't do that without reform. Again, I'm not a healthcare expert, so you're the guys in the room who know where all that is. I saw on your agenda that you're going to be discussing the Supreme Court's, weighings in and so on. From the front line, I will tell you that unless there's more time and money and resource put into primary care, we're just going to breed a more and more expensive system with no end in sight. Sir.
Thank you, Dr. Raju, for Cook County Health and Hospital System. I really enjoyed your lecture, and I went to the same medical school you went to, so I just want to let you know that Madras Medical College.
By the way, that was a public hospital too. It had 1,500 beds and another 2,500 sleeping under and between the beds. So tremendous.
That's the only place where the patients kept their own charts, and we never lost a chart. So, so the issue was, you're absolutely correct. That one of the striking things in my own transformation was the fact that you are right. But unfortunately, the system we have in medical schools of how I get my medical school diploma or get my board certification basically depends on exams which I interpret, the lab values and the x-rays. You could be a completely dispassionate doctor, which absolutely no bedside manners, and you are probably no skills as a surgeon. So long you know the books and you know how to interpret the labs and the x-rays, you'll get your board certification. So if you want to really put an emphasis on the compassion part of it, the bedside manners part of it, as well as the skill part of it, then the way we examine our medical students and our residents need to fundamentally change. And I'm not sure the American medical schools are willing to take that as a matter of doing that, which is a big difference between what happens in England, where I got trained, where you have to get your skill level, as also you have to examine the patients in the presence of your examiners and basically make those right decisions, how we communicate with that at some level. Yeah, so how do you do this?
Well, I think you've hit on a very important point, one that I've been lobbying for some time. I was on the American Board of Internal Medicine. And the American Board of Internal Medicine, I was certified in internal medicine, as you point out, largely based on a multiple choice test. And the public would be scandalized if they realized that all our board certifications are largely multiple choice tests. It would be the equivalent of allowing people to fly you on a plane when they've never really flown in anybody's presence. No one's really tested them. But theoretically, they can fly. And when I was in the American Board of Medicine, I agitated a lot for a high-stakes bedside exam. I think the public expects this of us. But I felt that I was up against what I call the psychometric mafia. And the psychometric mafia felt that if you couldn't reproduce it, to the nth degree, then it wasn't valid. And I admit that bedside tests of clinical skill can be somewhat subjective. They were very subjective when we were training. Nevertheless, I think they're better than nothing. And the fact that we decide, well, we're not going to test clinical skills because it's subjective and not reproducible, to me is like the drunk who's lost their keys in the dark and decides to go search under the street lamp. Because the light's there, but the keys are lost over there. And I think it's that equivalent. So I completely agree. I think short of a high-stakes clinical exam, we're doing lip service when we talk about people examining patients. we at Stanford feel that we're not going to wait for the American board, so we have in place, or we're putting in place, our own sort of thresholds and hurdles that our trainees should cross. And the wonderful thing is that they're hungry to do this. They recognize, especially now that knowledge has become democratic. I mean, knowledge has become democratic. Being a senior physician, I don't possess any more knowledge than the junior-most person, technically. I mean, they can find exactly what I know in seconds. And so, what differentiates people? I think it's very much the stuff at the bedside. So I quite agree with you. Sir?
Yes. Thank you very much. And I too, am from Texas. And
All right.
Francisco Figueroa probably sends his
Wonderful.
best regards to you.
Me too.
You know, I trained more than 30 years ago, and at that time we used to talk about the art of medicine and the science of medicine. And I agree with you. Unfortunately, these days we just talk about the science and not very much about the art. I've just been appointed to the Council on Graduate Medical Education, and we're looking at physician workforce issues. And we're going to have a physician shortage, particularly a primary care physician shortage in this country for what I believe will be quite a long time. And so there's this trend now of the primary care physician as manager, leading a team of other individuals, nurse practitioners, physician assistants, dietitians, other specialists, and that team managing a population of patients, and the physician maybe not having as much direct contact with the patient as has been the tradition. I'm curious to know what you think about that trend. Do you think it is appropriate? And is there an alternative that you would favor?
Yeah, actually, I'm a big fan of physician extenders. So even though it might seem like a new trend, to those of us who cut our teeth in the HIV era of the 80s, we couldn't have done it alone. We had the most wonderful PAs and volunteers, and I think that this is going to be the way primary care is. Even if we had plenty of primary care specialists, I think it clearly helps us to have physician extenders, people who can follow up on things that we might not be the best people to follow up on. So I'm all for it. I think that patients also respond to it well as long as they have access to the physician periodically. But my PA, when I was doing HIV care in Texas, they had the most wonderful relationships with patients and knew when to call me in, and I relied heavily on them. And it was a toss-up whether the patient wanted to see me or the PA from time to time, because really they could get excellent care from both of us. So I'm all for that, and I think that's the way to go. But you're right, I think without some change, we're in for a big shock. On the other hand, I can think of so many people who shouldn't be doing nasal reconstructive surgery or Botox injections or other things who are doing them. And why are they doing them? Because, the money is there. It's Sutton's Law. So I think if we put some money into primary care, a lot of people who, our specialists might say, I'd rather do primary care. It's less trouble, more interesting, more diverse. I don't do much infectious disease anymore myself. I do a lot of general medicine ward attending because I find it very challenging and I'm always learning. Infectious disease was interesting for many years. I can see more people doing that if we made it more, worth their while, worth their time. Sir.
Good morning. Philip Mahler from Denver Health. Thank you very much for your presentation. I think that the safety nets really are standing in a crucial role in this regard. I would submit to you that we all agree that perhaps a third of healthcare spending is overuse and unnecessary, and perhaps in the same vein, emergency room lengths of stays and hospital lengths of stay are being driven by residents ordering tests that are totally unnecessary if they would spend the time getting a history and examining the patient. And I think given the role of the safety net in resident education, we stand with NAPH really in a crucial role in that regard. If we could educate these residents, and if they actually spent a bit more time in the hospital that's now constrained by the house staff hour regulations and they have to leave and they don't really follow that patient, if we could help define that for American health, I think we could really put a big dent in this $800 or $900 million that we're spending on overuse and really get back to the basics that you've so eloquently described.
Yeah, I think we clearly overuse our technology a lot, and it's our fault for maybe not teaching our residents to do that. But we're just as guilty. My colleague Alan Garber at Stanford, actually he's no longer my colleague. He's become provost at Harvard. But Alan is a medical economist and an internist, and he wrote a lovely editorial almost a year ago now in the American Journal of Medicine, and it was titled American Healthcare, the Menu Without Prices. You know, the menu without prices. Like you can go, it's like going to a restaurant and you can order filet mignon every night. And honestly, when I'm attending on the wards with my house staff, we never stop to think about how much this test we think we want is going to cost. It never gives us pause. Somebody's paying for it. And I think that's the problem. So we can't really teach residents to be judicious about how they spend money on ordering tests when the system itself, you know, thrives on our ordering the test in a funny sort of way. And you know, it's like the perverse way our American economy works. It depends on middle-class consumer spending, which is fine, but if the consumers don't spend, everything grinds to a halt. It's sort of that same analogy. So as much as we want to educate the residents, the fact is that I think we're just as guilty. I don't know how much anything costs. It never gives me pause. I never stop to say, wait a minute, this is an indigent patient and they can't afford this bill when it arrives. Somebody's paying, and that's the problem. I think until we all are conscious of who's paying, until we realize we're paying, none of this is going to really happen. And it'll also bring in that word we hate, which is rationing care and, you know, being judicious about ordering, all of which doesn't sit well with the American public, so it's a little hard.
Hi, I'm Rachel Keegan from San Francisco General Hospital, and I thought that your presentation was very thought-provoking, and it made me reflect a little bit more on not just the physician-patient relationship, but also the whole organization's orientation, and looking at some of the current drivers with healthcare reform and also just with the field. I think of it as sort of the tension between creativity and empiricism, both of which are pushing forward. So on the one hand, we have quality measures and data being used to drive change, and things like Melissa referenced with the hitting these milestones and getting paid for those, or not getting paid if we hit them. But then going right along with that is the emphasis on patient experience and also getting paid or not paid based on that. And that is going to have to involve a lot more listening and a lot of things that we probably aren't in the habit of doing. And so I think it's going to be really interesting to see how these things complement and integrate each other, because they really aren't the same thing, but they are trying to drive towards the same goal of improving healthcare and improving both the quality, the empirical quality, but also the perceived quality that patients experience. And I wonder if that's something that's being thought through at all in sort of some of the ideas that you're
Well, I think that's very well said. I mean, and again, I'm not a QI sort of person. In fact, I must tell you, I think that one of the things that hurt us was our emphasis on quality to the exclusion of patient satisfaction. So quality became the buzzword for decades, and it led us all to be looking at screens, to be ticking ourselves, giving ourselves strokes for getting on the critical pathway. It didn't matter that you're on the wrong pathway. It didn't matter that the patient didn't need to be on the antibiotic that you delivered within 2 hours of their hitting the door. Hey, but you hit it, you know? And I think it led to sort of a perverse, you know, sort of, I don't know what the word is, a change of healthcare from being this, clearly we needed to raise quality. Clearly certain things have been huge. I'm not suggesting for a moment that we didn't need to. But it's interesting to see now how the emphasis has shifted to patient satisfaction. It might have been better if they'd come hand in hand.
Right.
Instead, we have this quality beast that's been let loose. And you know what? They spawn progeny, and the progeny spawn more progeny. And pretty soon, all your life is spent trying to meet indicators that you had no part in, you know, in deciding they were worthwhile or not. And I mean, day after day, I round and I meet someone who's labeled pneumonia, who actually didn't get enough dialysis and is just a bit fluid overloaded. And the hospital gets stars for having treated this pneumonia well. The dirty secret is only you and I know it wasn't pneumonia. Stuff like that's going on all the time. It's actually the opposite of quality. And I think what we need to do is a lot more emphasis on patient satisfaction, with quality coming after that or with that, hand in hand. I quite agree. Maybe the last question. I'm conscious of taking up time for the next speaker. I don't know where we are in time. How are we doing for time? Sir.
Just a quick question regarding your comments on workforce shortages, obviously in primary care, and then evolving models of team-based primary care. There's been recent press, I think, about the addressing.
Can you get a little closer to the mic?
I'm sorry about that. Regarding the workforce comments about primary care and the evolving team-based model for primary care delivery, and with your really acute observations about the value of physical exam. There was recent press, I thought, about the value of annual physicals, which is a big concept, almost a myth in American medicine. I think a lot of the articles may have been focused about generating unnecessary tests with false positives.
Right.
But simply as that, I'm interested in your comments on the ongoing value of the concept of annual physicals, particularly for various populations.
Yeah, I think the annual physical is clearly, for someone who's otherwise healthy, an annual physical, it's been shown, has very low yield. Nevertheless, it's a great opportunity to meet the patient, counsel them about stopping smoking, weight loss, whatever else they need to. But the yield on a physical like that with someone with no symptoms is actually fairly low. But the yield on someone coming in and saying, it's hurting me here, if you don't strip that part and take a look, or maybe even feel above the collar and find that there's a lymph node mass that explains why they're hurting here, this is stomach CA that's metastasized, then I think you're sort of going against something that, in the 1800s they were doing better than we were doing. So I completely agree with you. When I use the word physical, I especially worry that people take it to mean the annual physical, but I don't mean that. I mean more a physical pertaining to whatever it is they've come to see you. And even if you find nothing, they've come to see you with a complaint, you find nothing on the physical, you're validating that you're looking on the body as opposed to on the screen for something in them. And I think that's the first beginning, is always by examining them. I'll stop here. I came this morning from sunny Palo Alto, where I had to tell the driver to turn the air conditioning on, loosen my tie. I was sweating, and by the time we hit Burlingame, the mist was falling, the fog was rolling in. So I hope you have an opportunity to have some good weather and maybe get to drive out a little bit south and get some sunshine from time to time. Thank you very much.